Hi, welcome to our channel of ignou audiobooks. Indira Gandhi National Open University, School of Social Sciences, SOSS, Master's Degree Programs, MA in Psychology, MAP, Second Year, MPCE 0 to 1 Counseling Psychology, Block-3 Types of Counseling, Unit-1 HIV-AIDS Counseling, 1.0 Introduction. AIDS stands for Acquired Immune Deficiency Syndrome, a disorder in which immune system is gradually weakened and eventually disabled by the human immunodeficiency virus, HIV. HIV testing and counseling services are a gateway to HIV prevention, care and treatment. The benefits of the knowledge of HIV status include the following. 1. At the individual level, enhanced ability to reduce the risk of acquiring or transmitting HIV, access to HIV care, treatment and support, and protection of unborn infants. 2. At the community level, a wider knowledge of HIV status and its links to interventions can lead to a reduction in denial, stigma and discrimination, and to collective responsibility and action. 3. At the population level, knowledge of HIV epidemiological trends can influence the policy environment, normalize HIV/AIDS and reduce stigma and discrimination in the communities that have been longest and hardest hit by the epidemic. An increasing number of people with HIV are becoming ill and need care, treatment, and support. However, most people with HIV are unaware of their HIV status. Scaling up HIV testing and counseling services is a critical step for scaling up a range of interventions in HIV/AIDS prevention, care, treatment, and support. In September 2003, WHO made a call to action for a target of providing access to ARV treatment for 3 million people in resource-limited settings by 2005 and of working towards universal access. This requires that many more millions of people be tested for HIV and counseled in order to identify those who can benefit from immediate access to treatment and to prevention and support services. Indeed, the increased availability of ARV treatment is likely to generate a dramatically increased demand for HIV testing and counseling. In June 2006, a number of documents relating to the policy and provision of HIV testing and counseling to infants and children were added to the toolkit. They include a selection of documents covering policies, child's rights and strategic frameworks, child-focused counseling, consent, confidentiality and disclosure, clinical diagnosis and laboratory issues, monitoring and evaluation and case studies. WHO and UNAIDS released in May 2007 the Guidance to Provider-Initiated HIV Testing and Counseling in Health Facilities, which articulates recommendations developed over the course of a year-long consultation with many different stakeholders. This guidance, which builds on previous policy positions of both WHO and UNAIDS, encourages healthcare providers to routinely recommend HIV testing and counseling to all patients who present with conditions that suggest underlying HIV infection. HIV/AIDS is one of the most serious diseases. However, since the modes of transmission are well known, awareness is the best method to reduce the occurrence of this disease. At present, prevention is the only way to handle this crisis, which has become a global menace. 1.1 Objectives. At the end of the unit, you will be able to know the meaning of HIV and AIDS, understand how does HIV and AIDS occur, recognize the sign and symptoms of HIV/AIDS, aware of the myths and facts about HIV/AIDS, explain the diagnosis of HIV, describe the aims of HIV counseling, and understand the importance of prevention of HIV. 1.2 What is HIV/AIDS? HIV is a virus which causes impairment to the immune system in the humans. HIV stands for human immunodeficiency virus. These belong to the family of virus called retrovirus. This looks like a sunflower in a full bloom, which is 1,000 times smaller than the thickness of hair. AIDS stands for Acquired Immunodeficiency Syndrome. HIV is the virus that causes AIDS, Redfield, Wright and Tramond explain AIDS as a acquired means which is taken from somebody else and there is no genetic inheritance, id immune deficiency that is. The immune system becomes so weak and inadequate that the body is unable to fight against the disease, a syndrome when group of diseases or symptoms are present and a person is unable to cope with it. The HIV attacks our immune system, which is our body's security force to fight off infections. Once the HIV enters the body, it weakens the body's immune system. HIV mostly infects T cells, also known as CD4 cells or T helper cells. These cells are white blood cells that activate the immune system to fight disease. Once inside the cell, HIV starts producing millions of little viruses, which eventually kill the cell and then go out to infect other cells. With the breakdown of the immune system, the body becomes susceptible to numerous infections. These are called opportunistic infections because they take advantage of the body's weakened defenses. Thus, HIV virus itself does not cause death. It is the opportunistic infections that cause death. AIDS is the condition where many opportunistic infections take hold of the body. When the person is infected with HIV, he may remain asymptomatic for several years, that is, he does not suffer from any illnesses as a result of lower immunity. It may develop into AIDS after a number of years. People with HIV may not know that they have the virus, but can pass on the virus to others. 1.2.1 How does it transmit? There are three main modes of transmission. 1. Unprotected sex. Engaging in unprotected, unsafe sex, i.e. not using condom or any other barrier devices, leads to the risk of HIV infection. In fact, heterosexual transmission is the route by which most people with AIDS have become infected with HIV worldwide. A significant portion of HIV infection among women in the world is acquired through heterosexual contact. HIV can be found in the blood, semen, preseminal fluid, or vaginal fluid of a person infected with the virus. 2. Blood exposures. Various blood exposures that carry risks of HIV transmission include injections, intramuscular, subcutaneous, intravenous, blood tests, infusions, dental care, surgery, other medical procedures, tattooing, piercing, shaving, manicures, and pedicures, when cuts occur, and needle stick accidents. Sharing of syringes, needles or injecting equipments carry high risks of HIV infection. HIV can also be transmitted through other body fluids such as semen, vaginal fluid, breast milk, cerebrospinal fluid, which surrounds the brain, and the spinal cord, synovial fluid, which surrounds bone joints, and amniotic fluid, which surrounds a fetus. Though HIV is also present in other body fluids, such as saliva and sweat, it is present in such low quantities that transmission through these routes is impossible. Thus, HIV is not spread through these body fluids. Times sweat, times tears, times saliva, spit. 3. Mother-to-baby transmission. HIV can be transmitted through an infected, pregnant woman to her baby during pregnancy or delivery, as well as through breastfeeding. Thus, transmission of HIV most often occurs through unprotected sex, through the transfer of contaminated blood from one infected person to another, through infected pregnant women. However, HIV is not transmitted through casual contacts like hugging, kissing, between people with no significant dental problems, dancing, sharing food or drinks, sharing exercise equipment, using a shower, bath, or bed used by an HIV person. Insect bites. The counselor must be clear of the fact that no matter how a person became infected, they are facing a serious and life-threatening disease. Therefore, the counselor must have an objective and empathetic attitude towards the HIV-affected person. Counselor must take each case separately and must make a preparation for the counseling program to help the patient. 1.2.2 Signs and symptoms of HIV/AIDS. Most people with HIV are asymptomatic for 8 to 10 years, although it only takes 3 to 10 weeks for the body to initially respond to infection by the HIV virus by producing antibodies. The progression of HIV in the body is times HIV infection, entry of virus in the body through any of routes, times window period, few weeks to few months, times silent infection, no symptoms seen for 5 to 8 years. The window period is a term used to describe the period of time between HIV infection and the production of antibodies. During this time, an antibody test may give a false negative result, which means the test will be negative, even though a person is infected with HIV. To avoid false negative results, antibody tests are recommended 3 months after potential exposure to HIV infection. A negative test at 3 months will almost always mean a person is not infected with HIV. If an individual's test is still negative at 6 months, and they have not been at risk of HIV infection in the meantime, it means they are not infected with HIV. It is very important to note that if a person is infected with HIV, they can still transmit the virus to others during the window period. HIV may lead to AIDS. The symptoms of AIDS vary widely depending on the specific constellation of disease that one develops. Cunningham-Selvin, 2005. Unfortunately, the worldwide prevalence of this deadly disease continues to increase at an alarming rate, so the counselor must be aware of the following symptoms, which can be classified into major and minor. The major symptoms are as following: 1. Chronic or recurring diarrhea. 2. Unexplained low-grade fever more than a month's duration. 3. Dry cough. 4. Fatigue. 5. Progressive dementia. 6. Progressive involuntary weight loss of 10% of the known body weight. 7. Recurrent respiratory infections with poor response to microbial. The minor symptoms are as following: 1. Oral thrush. 2. Recurrent or multi-dermatomes herpes zoster recurrent skin infection. 3. Severe seborrhea dermatitis. 4. Pneumonia. NACO guidelines. Below is given the NACO, National AIDS Control Organization, guidelines for case definition of AIDS in India. Case definition for AIDS in India was revised in October 1999. The new case definition is as follows: I. Case definition of AIDS in children up to 12 years of age. 1. The positive tests for HIV infection by ERS, ELISA rapid simple, in children above 18 months, or confirmed maternal HIV infection for children less than 18 months, and 2. Presence of at least 2 major and 2 minor signs in the absence of known causes of immunosuppression. Major signs: A. Loss of weight or failure to thrive which is not known to be due to medical causes other than HIV infection. B. Chronic diarrhea, intermittent or continuous, 1 month duration. C. Prolonged fever, intermittent or continuous, 1 month duration. Minor signs: A. Repeat common infections, e.g. pneumonitis, otitis, pharyngitis, etc. B. Generalized lymphadenopathy. C. Oropharyngeal candidiasis. D. Persistent cough for more than 1 month. E. Disseminated maculopapular dermatosis. 2. Case definition of AIDS in adults. For persons above 12 years of age: 1. 2 positive tests for HIV infection by ERS test, ELISA rapid, simple, and 2. Any one of the following criteria: A. Significant weight loss, greater than 10% of body weight, within last 1 month, cachexia, not known to be due to a condition other than HIV infection. And chronic diarrhea, intermittent or continuous, 1 month duration, or prolonged fever, intermittent or continuous, 1 month duration. B. Tuberculosis, extensive pulmonary, disseminated, miliary, extrapulmonary tuberculosis. C. Neurological impairment preventing independent daily activities, not known to be due to the conditions unrelated to HIV infection. Example: trauma. D. Candidiasis of the esophagus, diagnosable by oral candidiasis with odonophagia. E. Clinically diagnosed life threatening or recurrent episodes of pneumonia, with or without etiological confirmation. F. Kaposi sarcoma. G. Other conditions. times cryptococcal meningitis, times neurotoxoplasmosis, times CMV retinitis, times Penicillium malafie, times recurrent herpes zoster or multidermatomal herpes infection. 1.3 Diagnosis of HIV/AIDS. HIV test involves detecting antibodies of the virus or the genetic material, DNA, or RNA, of HIV in the blood or other sample. If this is present, the person is called HIV positive. After the original infection, it takes between 2 weeks and 6 months for antibodies to HIV to appear in the blood. The period between becoming infected with HIV and the point at which antibodies to HIV can be detected in the blood is called the seroconversion or window period. During this period, an HIV-infected person can still spread the disease, even though a test will not detect any antibodies. In his or her blood, several tests can find antibodies or genetic material, RNA, to the HIV virus. These tests include times enzyme-linked immunosorbent assay, ELISA. This test is usually the first one used to detect infection with HIV. If antibodies to HIV are present, positive, the test is usually repeated to confirm the diagnosis. If ELISA is negative, other tests are not usually needed. This test has a low chance of having a false result after the first few weeks that a person is infected. Times Western blot. This test is more difficult than the ELISA to perform, but it is done to confirm the results of 2 positive ELISA tests. Times polymerase chain reaction, PCR. This test finds either the RNA of the HIV virus or the HIV DNA in white blood cells infected with the virus. PCR testing is not done as frequently as antibody testing because it requires technical skill and expensive equipment. This test may be done in the days or weeks after exposure to the virus. Genetic material may be found even if other tests are negative for the virus. The PCR test is very useful to find a very recent infection, determine if an HIV infection is present when antibody test results were uncertain, and screen blood or organs for HIV before donation. Testing is often done at 6 weeks, 3 months, and 6 months after exposure to find out if a person is infected with HIV. 1.4 Misconceptions. Misconception about AIDS is widespread. A great many people have unrealistic fears that AIDS can be readily transmitted through casual contact with infected person. These people worry unnecessarily about contracting AIDS from a handshake, a sneeze, or from a utensil. Many young heterosexuals who are sexually active with a variety of partners foolishly downplay their risk for HIV, naively assuming that they are safe as long as they avoid drugs use and sexual relation with gay or bisexual men. They generally underestimate the probability that their sexual partners may have previously used drugs or unprotected sex with an infected individual. People generally think that AIDS is usually accompanied by discernible symptoms. Their prospective sexual partners who carry HIV virus will carry telltale signs of illness. However, having AIDS and being infected with HIV are not the same thing, and HIV carriers often remain healthy and symptom-free for many years after they are infected. Hence, there is a crucial need to create public awareness and educate them about AIDS. Below are given some of the myths about the AIDS and the facts. Myth: having HIV means you have AIDS. Fact: human immunodeficiency virus, HIV, is a virus that destroys the body's CD4 immune cells, which help fight disease. With the right medications, you can have HIV for years or decades without HIV progressing to AIDS. AIDS, acquired immunodeficiency syndrome, is diagnosed when you have HIV as well as certain opportunistic infections or your CD4 cell count drops below 200. Myth: HIV/AIDS can be acquired through casual contact. Fact: HIV/AIDS cannot be acquired through hugging, using the same towel, or sharing the same glass or utensil. However, the risk of infection comes from having unprotected sex, sharing needles, or getting a tattoo from unsterilized equipment. Myth: an HIV-infected person has just a few years to live. Fact: everyone with HIV experiences it differently. Some people may develop AIDS within a few months as the virus quickly weakens their immune system. Many others can live for decades with HIV and have a normal life expectancy. You can help prevent HIV from progressing to AIDS by seeing your doctor regularly and following your doctor's recommendations. Myth: HIV always shows off through its symptoms. Fact: some people don't show any signs of HIV for years after being infected. Many can have some symptoms within 10 days to a few weeks after infection. These first symptoms are similar to the flu or mononucleosis and may include fever, fatigue, rash, and sore throat. They usually disappear after a few weeks, and you may not have symptoms again for several years. The only way to tell you have HIV is to get tested. Myth: HIV can be cured. Fact: there is no cure for HIV, but treatment can keep virus levels low and help maintain the immune system. Some drugs interfere with proteins HIV needs to copy itself. Others block the virus from entering or inserting its genetic material into your immune cells. Your doctor will consider your general health, the health of your immune system, and the amount of virus in your body to decide when to start treatment. Myth: HIV cannot affect me and my family. Fact: anyone can get HIV, men, women, and children. Many people are silent carriers of HIV, even they themselves are unaware of this. HIV gets spread through unsafe sex, infected syringes, and blood, and from infected mothers. Myth: sex is safe when both partners have HIV. Fact: just because you and your partner both have HIV doesn't mean you should forget about protection when you have sex. Using a condom or other latex barrier can help protect you from other sexually transmitted diseases as well as other strains of HIV, which may be resistant to anti-HIV medication. Even if you are being treated and feel well, you can still infect others. Myth: you cannot have a baby if you are HIV positive. Fact: infected mothers can indeed pass HIV to their babies during pregnancy or delivery. However, you can lower the risk by working with your doctor and getting the appropriate care and medication. Pregnant women with HIV can take medications to treat their infection and to protect their babies against the virus. 1.5 Prevalence of HIV-AIDS in Asian countries. Statistics reported the rise in incidence of HIV-AIDS in the Asian countries by the surveys done by various international organizations, UN, UNICEF, etc., after the late 80s. Facts rate that around 31,000 children below the age of 15 are surviving with HIV-AIDS in the Asian countries in East and the Pacific, with 11,000 newly infected in the year 2007, and the number could exceed around 25,000 in 2015, according to Global Action for Children, NGO. Times approximately 2.2 million children are affected from HIV-AIDS worldwide. Times largest number of HIV-AIDS orphans in the world. Times 2/3 of the India's cases are reported in the 6 of 28 states c.g. Maharashtra, AP, Manipur, Karnataka, TN, Nagaland. The figures above suggest the need for awareness regarding HIV/AIDS and taking preventive measures through counseling and large-scale awareness generation program and by conducting workshops for the teenagers. Women are biologically and socially more prone to HIV infection than men. The low status of women in society inhibits their ability to protect themselves from HIV infection coming either from their husbands or other sex partners. 1.6 Aims of HIV/AIDS counseling. Counseling in HIV and AIDS has become a core element in a holistic model of healthcare, in which psychological issues are recognized as integral to patient management. It concentrates specifically on emotional and social issues related to possible or actual infection with HIV and to AIDS. With the consent of the client, counseling can be extended to spouses, sex partners, and relatives. family-level counseling, based on the concept of shared confidentiality. HIV counseling has as its objectives both prevention and care. UNAIDS Technical Update, Geneva, 1997. HIV and AIDS counseling can have two general aims: 1. Prevention of HIV transmission. 2. Provision of counseling services to the AIDS patients and their family. 1.6.1 Prevention of HIV transmission. It is vital that HIV counseling should have these dual aims because the spread of HIV can be prevented by changes in behavior. One-to-one prevention counseling has a particular contribution in that it enables frank discussion of sensitive aspects of a patient's life. Such discussion may be hampered in other settings by the patient's concern for confidentiality or anxiety about a judgmental response. Also, when patients know that they have HIV infection or disease, they may suffer great psychosocial and psychological stresses through a fear of rejection, social stigma, disease progression, and the uncertainties associated with future management of HIV. Good clinical management requires that such issues be managed with consistency and professionalism, and counseling can minimize both morbidity and reduce its occurrence. All counselors in this field should have formal counseling training. 1.6 Aims of HIV/AIDS counseling. Counseling in HIV and AIDS has become a core element in a holistic model of healthcare, in which psychological issues are recognized as integral to patient management. It concentrates specifically on emotional and social issues related to possible or actual infection with HIV and to AIDS. With the consent of the client, counseling can be extended to spouses, sex partners, and relatives. Family-level counseling, based on the concept of shared confidentiality. HIV counseling has as its objectives both prevention and care. UNAIDS Technical Update, Geneva, 1997. HIV and AIDS counseling can have two general aims: 1. Prevention of HIV transmission. 2. Provision of counseling services to the AIDS patients and their family. 1.6.1 Prevention of HIV transmission. It is vital that HIV counseling should have these dual aims because the spread of HIV can be prevented by changes in behavior. One-to-one prevention counseling has a particular contribution in that it enables frank discussion of sensitive aspects of a patient's life. Such discussion may be hampered in other settings by the patient's concern for confidentiality or anxiety about a judgmental response. Also, when patients know that they have HIV infection or disease, they may suffer great psychosocial and psychological stresses through a fear of rejection, social stigma, disease progression, and the uncertainties associated with future management of HIV. Good clinical management requires that such issues be managed with consistency and professionalism, and counseling can minimize both morbidity and reduce its occurrence. All counselors in this field should have formal counseling training. 1.6 Aims of HIV/AIDS counseling. Counseling in HIV and AIDS has become a core element in a holistic model of healthcare, in which psychological issues are recognized as integral to patient management. It concentrates specifically on emotional and social issues related to possible or actual infection with HIV and to AIDS. With the consent of the client, counseling can be extended to spouses, sex partners, and relatives. Family-level counseling, based on the concept of shared confidentiality. HIV counseling has as its objectives both prevention and care. UNAIDS Technical Update, Geneva, 1997. HIV and AIDS counseling can have two general aims: 1. Prevention of HIV transmission. 2. Provision of counseling services to the AIDS patients and their family. 1.6.1 Prevention of HIV transmission. It is vital that HIV counseling should have these dual aims because the spread of HIV can be prevented by changes in behavior. One-to-one prevention counseling has a particular contribution in that it enables frank discussion of sensitive aspects of a patient's life. Such discussion may be hampered in other settings by the patient's concern for confidentiality or anxiety about a judgmental response. Also, when patients know that they have HIV infection or disease, they may suffer great psychosocial and psychological stresses through fear of rejection, social stigma, disease progression, and the uncertainties associated with future management of HIV. Good clinical management requires that such issues be managed with consistency and professionalism, and counseling can minimize both morbidity and reduce its occurrence. All counselors in this field should have formal counseling training and receive regular clinical supervision as part of adherence to good standards of clinical practice. Thus, prevention will include, in the first place, creating awareness among the public about the HIV/AIDS. Then, after a person is infected with HIV, prevention can focus on providing counseling to the person on how to live his life being a HIV carrier. 1.6.1.1 General awareness. A public awareness is the need of the hour to control the spread of this serious infection and disease which has physical, social, emotional, and occupational implications. The behavioral changes that minimize the risk of developing AIDS are fairly straightforward, although making the changes is often more easier said than done. Costs and cons. The more sexual partners a person has, the higher the risk that he or she will be exposed to the HIV virus. Thus, people can reduce their risk by following the practice of safe sex and being careful in matters of blood transmission, use of syringes, etc. Counseling can aim at the following points to spread the awareness about HIV, AIDS, times determining whether the lifestyle of an individual places him or her at risk, times behavior that put people at risk for AIDS HIV, times working with an individual so that he or she understands the risks, times helping to identify the meanings of high-risk behavior, times information about myths and facts for HIV AIDS, times how AIDS HIV is transmitted, times civic right issues related to HIV AIDS, times prevention and treatment for HIV AIDS. 1.6.1.2 Counseling to HIV-affected persons. Diagnosis of HIV infection brings with it profound social, emotional, and medical consequences. The adjustment to HIV infection involves constant stress, management in family life and workplace. The counselor need to be very sensitive about the feelings of the patients and should have empathic and positive attitude towards AIDS patients. A good rapport must be made which will help in breaking the diagnostic news of HIV in a positive way. The counselor must discuss and remove the misunderstandings about HIV transmission. Victims of HIV usually believe that nothing can be done now. These people have to be helped by developing a strong self-image to cope with the hardship of life without taking recourse to faulty methods of finding happiness or depression. Counseling should be given to prevent further deterioration or onset of full-blown AIDS, so as to remain healthy and live longer. By taking good personal care in terms of food, medicines, etc., people are likely to be distressed when informed that they are HIV positive. The primary challenges that they face are a changed new lifestyle they have to follow, such as accepting the possibility of shortened lifespan, coping with stigmas attached to the illness, reactions of others, coping with the personal relationships, adopting methods to remain emotionally healthy, initiating changes in behavior to prevent HIV transmission. Therefore, behavioral and psychological services are an integral part of health care for HIV-infected people. Whenever a person comes for HIV testing, there should be a pre-test and post-test counseling. Patients may present for testing for any number of reasons, ranging from a generalized anxiety about health to the presence of HIV-related physical symptoms. For patients at minimal risk of HIV infection, pre-test discussion provides a valuable opportunity for health education and for safer sex messages to be made relevant to the individual. For patients who are at risk of HIV infection, pre-test discussion is an essential part of post-test management. These patients may be particularly appropriate to refer for specialist counseling expertise. The following are some of the points which the counselor may cover in the pre-test Test and post-test discussion with the person who has come for HIV testing. Pre-test discussion checklist. Times what is the HIV antibody test, including seroconversion. Times the difference between HIV and AIDS. Times the window period for HIV testing. Times medical advantages of knowing HIV status and treatment options. Times transmission of HIV. Times high-risk sexual behavior. Times high-risk injecting drug practices. Times safer sex and risk reduction. Times safer injecting drug use. Times if the client were positive, how would the client cope? Personal resources, support network of friends, partner, family. Times who to tell about the test and the result. Times partner notification issues. Times HIV status of regular partner. Is partner aware of patient testing? Times confidentiality. Times does client need more time to consider? Times is further counseling indicated. Times how the results of the test are obtained in person from the counselor. Post-test counseling. HIV results should be given in a simple and straightforward manner in person. For HIV-negative patients, this may be a time where the information about risk reduction can be heard and further reinforced. With some patients, it may be appropriate to consider referral for further work on personal strategies to reduce risks, for example, one-to-one or group interventions. Many reactions to an HIV-positive diagnosis are part of the normal and expected range of responses to news of a chronic, potentially life-threatening medical condition. Many patients adjust extremely well with minimal intervention. Some will exhibit prolonged periods of distress, hostility, or other behaviors which are difficult to manage in a clinical setting. It should be noted that serious psychological maladjustment may indicate pre-existing morbidity and will require psychological psychiatric assessment and treatment. Depressed patients should always be assessed for suicidal ideation. Effective management requires allowing time for the shock of the news to sink in. There may be a period of emotional ventilation, including overt distress. The counselor should provide an assurance of strict confidentiality and rehearse, over time, the solutions to practical problems such as who to tell, what needs to be said. Discussion around safer sex practices and adherence to drug therapies. Clear information about medical and counseling follow-up should be given. Counseling may be of help for the patient's partner and other family members. Coping procedures rehearsed at the pre-test discussion stage will need to be reviewed in the context of the here and now. What plans does the patient have for today? Who can they be with this evening? Direct questions should be answered, but the focus is on plans for the immediate few days, when further review by the counselor should then take place. Practical arrangements including medical follow-up should be written down. Overloading the patient with information about HIV should be avoided at this stage. Sometimes this may happen because of the health professional's own anxiety rather than the patient's needs. Counseling support should be available to the patient in the weeks and months following the positive test results. Coping strategies given below may be suggested. Times using counseling, times problem solving, times participation in discussions about treatment, times using social and family networks, times use of alternative therapies, for example relaxation techniques, massage, times exploring individual potential for control over manageable issues, times disclosure of HIV status and using support options. The following are the different psychological responses to a HIV-positive test result. Shock is seen in terms of diagnosis, recognition of mortality, loss of hope for the future, etc. Fear and anxiety is a common feature which is seen in terms of uncertain prognosis, effects of medication and treatment failure, isolation and abandonment, and social sexual rejection. Infecting others and being infected by them, partners' reaction, etc. Depression is seen in adjustment to living with a chronic viral condition, absence of a cure, limits imposed by possible ill health, possible social, occupational, and sexual rejection if treatment fails, etc. Anger and frustration is expressed over becoming infected, having to adopt new and involuntary health lifestyle restrictions, Incorporating demanding drug regimens and possible side effects, guilt is the result of interpreting HIV as a punishment, for example, for being gay or using drugs, over anxiety caused to partner family, counseling patients and partners together. Counseling can also be offered to patients and their partner together. This should only take place with the patient's explicit consent, but it may be important for the following reasons. Times adjustments to sexual behavior and other lifestyle issues can be discussed and explained clearly to both times if the patient's partner is HIV negative, i.e. a serodiscordant couple. Particular care and attention must be paid to emotional and sexual consequences in the relationship. Times misconceptions about HIV transmission can be addressed and information on safe sex given. Times the partners and the patient's psychological responses to the diagnosis or result, such as anxiety or depression, can be explained and placed in a manageable perspective. Times there may be particular issues for couples who have children or who are hoping to have children or where the woman is pregnant. Partners and family members sometimes have greater difficulty in coming to terms with the knowledge of HIV infection than the patients do themselves. Individual counseling support is often required to manage this, particularly role changes within the relationship and other adjustment issues that may lead to difficulties. This is part of a holistic approach to the patient's overall health care. In many cases, the need for follow-up counseling may be episodic, and this seems appropriate given the long-term nature of HIV infection and the different challenges a patient may be faced with. The number of counseling sessions required during any of these periods largely depends on the individual presentation of the patient and the clinical judgment of the counselor. 1.6.2 Counseling the AIDS patients and family. AIDS is the final stage of HIV infection process, typically manifested about 7-10 years after the original infection. Carey Venable, 2003. With onset of AIDS, one is left virtually defenseless against a host of opportunistic infectious agents. The stages of AIDS HIV and its treatment are divided into 3 parts, where the counselor should be very vigilant. The first stage is known as asymptomatic stage, second is known as symptomatic stage, and third is known as end-of-life stage. 1. Asymptomatic stage. At this stage, the counselor must remember to treat the patient on food and nutrition, support, treatment with antiretroviral drugs, prevention of onward transmission. 2. Symptomatic stage. At this stage, the counselor must remember to help the patient on management of nutritional effects, treatment of HIV-related infections, medical care, and psychological support. 3. End of the life stage. In this stage, the counselor's role is very important, because the counselor not only helps the patient but the family also. As the patient and family is under depression and grief, the counselor should make the patient emotionally strong for the truth, death, and prepare him for death, by which she not only enables the family to accept the fact of life but also help the patient to live the remaining life to the fullest. AIDS cannot be cured. The only way out is the prevention. Various treatments are given to the AIDS patient to fight with the infections. The antiretroviral treatment has been found to be useful. However, patient adherence is an important factor in the efficacy of drug regimens. The presence of side effects can often make patients feel more unwell, and some may be unable to cope with the side effects. Counseling may be an important tool in determining a realistic assessment of individual adherence and in supporting the complex adjustment to a daily routine of medication. It is very crucial to provide support to those affected directly and indirectly by HIV. Hence, individual, relationship, family counseling and support groups are of great help to enable the patient and his/her family to adjust and cope up with the various aspects and issues of life. 1.7 Summary. In this unit you learned about the HIV/AIDS and understood the serious threat it poses to our society. However, if we can spread the awareness, it can be prevented well. Counselors need to play an important role in creating awareness through writing, role plays, film talks, lectures, campaign educative programs about AIDS HIV. You learn the different ways of transmission of HIV and the signs and symptoms of HIV/AIDS. The various myths prevalent on HIV were described. Finally, the need and importance of HIV/AIDS counseling is discussed. This is crucial in terms of making the patient as well as the family members cope up with life-changing disease. Even with the significant medical advances in patient management, counseling remains an integral part of the management of patients with HIV and their partners and family. HIV testing and counseling services are a gateway to HIV prevention, care, and treatment. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.